The lungs are a pair of air-filled organs located in the thoracic cavity on the left and right side, separated by a central mediastinum, which contains the heart, thoracic parts of the great vessels, thoracic parts of the trachea, esophagus, thymus, and other structures. It's also important to notice that the heart is turned and extends towards the left side of the thoracic cavity, imposing on the left lung markedly more than the right, so the anatomy of the two lungs is not completely symmetrical. Each lung is covered by a membrane called the pleura, which is subdivided into the visceral pleura that intimately adheres to the lung, and the parietal pleura that lines the pulmonary cavity. Between them, there's a pleural cavity, which is normally filled with a thin film of fluid. Now, on the medial part of each lung, there's a pulmonary hilum, where the root of the lung passes through. The root of the lungs is made up of structures like the main bronchus, arteries, and veins. The lungs are light, soft, and spongy, and each of them has an apex, a base, and three surfaces: costal, mediastinal, and diaphragmatic, and three borders: anterior, inferior, and posterior. The apex is the blunt superior end of the lung above the level of the first rib into the root of the neck, while the base is the concave inferior surface of the lung that rests on the diaphragm. Now for the specifics. The right lung is larger and heavier than the left, but it's shorter and wider because the right dome of the diaphragm is higher and the heart and pericardium are more to the left. The right lung is divided into three lobes: superior, middle, and inferior, by the horizontal fissure and the oblique fissure, which can be seen on all surfaces of the lung. On the other hand, the left lung has a single left oblique fissure, which can also be seen on all surfaces, and divides the left lung into two lobes, superior and inferior. Also on the left lung, there's a deep cardiac notch on the anterior border, caused by the deviation of the heart towards the left. This leaves an impression on the anterior-inferior aspect of the superior lobe, and also shapes a tongue-like process called the lingula. The lingula extends below the cardiac notch and goes in and out of the costomediastinal recess during breathing. Next, there are the lung surfaces. The costal surface of both lungs is large, smooth, and convex, and related to the costal pleura, which separates it from the ribs, costal cartilages, and intercostal muscles. The posterior part of the costal surface is in relation to the bodies of the thoracic vertebrae, sometimes called the vertebral part of the costal surface. The diaphragmatic surface of the lung, also concave, forms the base of the lung, which rests on the dome of the diaphragm. The concavity is deeper in the right lung because the right dome is higher due to the liver sitting below. Finally, the mediastinal surface of the lung is concave because it's related to the middle mediastinum, which contains the pericardium and heart. This surface includes the hilum, which receives the root of the lung. On an embalmed cadaver, several impressions can be seen on the mediastinal surface of the lung. On the right lung, there's a groove for the esophagus and arch of the azygos vein, as it arches superior to the lung hilum to drain into the superior vena cava, which may also cause a groove in the right lung. Both lungs also have a cardiac compression for the heart, where on the left lung, there's a much larger cardiac compression as the heart apex is directed towards the left. The left lung will also have a continuous groove for the arch of the aorta, as well as a descending aorta and a smaller area for the esophagus. And just a few words on borders. The anterior border is where the costal and mediastinal surfaces meet anteriorly. On the right lung, it's almost straight, while on the left lung, it's deviated by the cardiac notch. The inferior border is thin and sharp and bounds the diaphragmatic surface of the lung and separates it from the costal and mediastinal surfaces. It also projects into the costodiaphragmatic recess of the pleura. The posterior border is where the costal and mediastinal surfaces meet posteriorly, and it's broad and rounded, and lies at the side of the thoracic region of the vertebral column. The lungs are attached to the mediastinum by the roots of the lungs, made up by the bronchi and associated bronchial vessels, the pulmonary arteries, the superior and inferior pulmonary veins, as well as the pulmonary plexuses of nerves and lymphatic vessels. On a section of the right and left lung root, we can identify the position of the main bronchus and the pulmonary artery and vein in relationship to one another. But keep in mind there may be slight variations from person to person. First, the main bronchus is typically against the posterior middle boundary in both lung roots. Depending on the precise location of the section, you may see the main bronchus dividing into the superior lobar bronchus and intermediate bronchus on the right, and into the superior lobar bronchus and inferior lobar bronchus on the left. On anatomical dissection, the bronchus is easiest to identify due to its firm cartilaginous structure when feeling it. Second, the pulmonary artery is the superiormost structure on both the left and right roots. However, on the right side, you may see the first two branches of the pulmonary artery. Third, the superior and inferior pulmonary veins are typically the anteriormost and inferiormost structures on both lung roots. These roots enter and exit the lungs through a doorway that is called the hilum of the lung, similar to how the roots of a plant enter into the ground. Medial to the hilum, towards the central mediastinum, the lung root is enclosed within the area of continuity between the parietal and visceral layers of the pleura. Inferior to the root of the lung, this continuity between parietal and visceral pleura forms the pulmonary ligament, which extends between the lung and mediastinum, directly anterior to the esophagus. The pulmonary ligament consists of a double layer of pleura, separated by a small amount of connective tissue. To visualize this, think of wearing a large lab coat. Your forearm represents the root of the lung, and the sleeve is the pleura, which, if it's too large, will droop down in a double layer. Now let's play a game and see if you can tell which lung is which, based on their external appearance. Alright, now let's look at the tracheobronchial tree, which starts with the trachea right below the larynx. Below the larynx, the walls of the trachea are surrounded by C-shaped rings of hyaline cartilage. The trachea bifurcates into two main bronchi, or primary bronchi, at the level of the transverse thoracic plane, or sternal angle. They pass inferolaterally to enter the lungs at each hilum. The right main bronchus is wider, shorter, and has a more vertical trajectory than the left one, and passes directly into the right hilum. The left main bronchus passes inferolaterally, inferior to the aortic arch, and anterior to the esophagus and thoracic aorta to reach the left hilum. Now, within each lung, the main bronchi divide to form the branches of the tracheobronchial tree, all of which actually belong to the root of the lung. Each main bronchus divides into the secondary lobar bronchi, each of which supply a lobe of the lung. So, on the right, there are three secondary lobar bronchi: right superior lobar bronchus, right middle lobar bronchus, and right lower lobar bronchus. The portion of the right main bronchus that continues inferiorly and gives rise to the middle and lower lobar bronchi is often referred to as the intermediate bronchus. On the left, there are only two lobar bronchi, the left superior lobar bronchus and the left inferior lobar bronchus. Each secondary lobar bronchus then divides into several tertiary segmental bronchi that supply the bronchopulmonary segments. Each bronchopulmonary segment is independently supplied by a tertiary segmental bronchus, in addition to a branch of the pulmonary artery. So there's 10 bronchopulmonary segments for the right lung and 8 to 10 for the left lung, as some of the segments may be combined. These bronchopulmonary segments are functionally distinct segments, which is important for surgeons who operate on lungs. In both lungs, the superior lobe has an apical, posterior, and anterior segment, where the apical and posterior segment may be combined on the left. Furthermore, the left superior lobe also has a superior lingular and inferior lingular segment. Because the right lung has a middle lobe, the middle lobe has a lateral and medial segment, which are the counterparts to the superior lingular and inferior lingular segments. Finally, both of the lung's lower lobes have a superior segment, along with an anterior, posterior, medial, and lateral basal segment, where in the left lung, the anterior and medial segments may be combined. Beyond the tertiary segmental bronchi, the tracheobronchial tree branches 20 to 25 more times, resulting in about 20 to 25 generations of branching conducting bronchioles. Finally, conducting bronchioles end as terminal bronchioles, which are the smallest conducting bronchioles and don't have any cartilage in their walls. Each terminal bronchiole gives rise to several generations of respiratory bronchioles, which have scattered alveoli, or thin-walled outpouchings, extending from their lumens. The pulmonary alveolus is the basic structural unit of gas exchange. Due to these tiny structures, the respiratory bronchioles can transport air and exchange gas. Each respiratory bronchiole gives rise to 2 to 11 alveolar ducts, each of which gives rise to 5 to 6 alveolar sacs. Alveolar ducts are elongated airways lined with alveoli, leading to the alveolar sacs where clusters of alveoli open. When thinking of the blood supply to the lungs, you need to consider two different circuits. First, they have a functional circulation, where low oxygen blood comes from the heart and reaches the lungs in order to exchange carbon dioxide with oxygen from all the tissues throughout the body. Then there's a nutritive circulation, which also comes from the heart, but this time, oxygenated blood nourishes the lungs themselves. Regarding functional or pulmonary circulation, briefly speaking, each lung has a pulmonary artery supplying low oxygen blood to it and two pulmonary veins draining oxygenated blood from it. The right and left pulmonary artery arise from the pulmonary trunk at the level of the sternal angle, and they carry low oxygen blood to the lungs. Although they're called arteries, they're colored blue just like veins in almost all anatomical illustrations, because they transport low oxygenated blood. Each pulmonary artery becomes part of the root and then divides into secondary lobar arteries. At this point, let's keep in mind that the arteries pair together with the bronchi and usually sit anterior to them. The right and left superior lobar arteries to the superior lobes arise first, even before entering the hilum. Continuing into the lung, the artery descends posteriorly and laterally to the main bronchus. In the right lung, it continues as the intermediate artery that will divide into middle and inferior lobar arteries, and in the left lung, it continues as the inferior lobar artery. Lobar arteries further divide into tertiary segmental arteries, which are what supply the bronchopulmonary segments. Two pulmonary veins, a superior and an inferior pulmonary vein on each side, carry oxygen-rich blood from the lungs to the left atrium of the heart. Because they carry oxygen-rich blood, they're colored red in medical illustrations. Unlike the pulmonary arteries, the pulmonary veins don't buddy up with respective bronchi and arteries. They just course within the lung, receiving oxygenated blood from adjacent bronchopulmonary segments. The veins from the visceral pleura and the bronchial venous circulation drain into the pulmonary veins, with the exception of the central perihilar region of the lung. This means that a small volume of low oxygen blood enters a large volume of oxygenated blood. Regarding the nutritive or bronchial circulation, there are two left bronchial arteries and a single right bronchial artery that supply the root of the lungs, tissues of the lungs, and the visceral pleura. The parietal pleura is typically supplied by the arteries supplying the thoracic wall. Now, the two left bronchial arteries usually arise from the thoracic aorta. The right bronchial artery usually arises either from the proximal part of one of the upper posterior intercostal arteries, usually the third posterior intercostal artery, or from a common trunk with the left superior bronchial artery. Sometimes a single right bronchial artery may arise directly from the aorta. The bronchial arteries also provide branches to the upper esophagus. The bronchial arteries pass on the posterior aspect of the main bronchi and supply all the branches as far as the respiratory bronchioles. The most distal branches of the bronchial arteries anastomose with branches of the pulmonary arteries in the walls of the bronchioles, and also in the visceral pleura. The right and left bronchial veins only drain the part of the blood that's distributed near the more proximal part of the root, and they also drain some blood from the esophageal veins. The right bronchial vein drains into the azygous vein, while the left bronchial vein drains into the accessory hemiazygous vein, or into the left superior intercostal vein. The blood returning from the visceral pleura, as well as from the more peripheral regions of the lung, and the distal components of the root, is drained by the pulmonary veins. While we're at it, let's not forget about the lymphatics of the lungs. First, there are two lymphatic plexuses, a superficial and a deep one, which communicate freely. The superficial or subpleural plexus lies deep to the visceral pleura and drains the visceral pleura and lung tissue. Lymphatic vessels from this plexus drain into the bronchopulmonary or hilar lymph nodes located in the region of the lung hilum. The deep lymphatic plexus is located in the submucosa of the bronchi and in the peribronchial connective tissue, and it drains the structures that make up the root of the lung. Lymphatic vessels here continue to follow the bronchi and pulmonary vessels in the hilum, where they also drain into the bronchopulmonary lymph nodes. At this point, lymph from both the superficial and deep plexi drain to the superior and inferior tracheobronchial lymph nodes, which are located superior and inferior to the bifurcation of the trachea. The right lung drains primarily through the consecutive nodes on the right side, and the superior left lobe drains primarily through the corresponding nodes on the left. However, a lot of the lymphatics from the lower lobe of the left lung drain to the right superior tracheobronchial nodes. Now, lymph from the tracheobronchial lymph nodes passes to the right and left bronchomediastinal lymph trunks, which are the major conduits that are draining the thoracic viscera. They usually end on each side at the venous angles, which are the junctions of the subclavian and internal jugular veins. Finally, lymph from the parietal pleura drains into the lymph nodes of the thoracic wall, and a few lymphatics from the cervical parietal pleura drain into the axillary lymph nodes. After having fun with the lymphatics, let's now tackle the nerves of the lungs and pleura. The nerves of the lungs and visceral pleura come from the pulmonary plexuses, located anterior and posterior to the roots of the lungs, and contain parasympathetic, sympathetic, and visceral afferent fibers. The parasympathetic fibers conveyed to the pulmonary plexus are presynaptic fibers from the vagus nerve. They synapse with the parasympathetic ganglion cells in the pulmonary plexuses and along the branches of the bronchial tree. The parasympathetic fibers are active during rest mode, so they cause bronchoconstriction of the smooth muscle in the bronchial tree, vasodilation of the pulmonary vessels through inhibition, and secretion of glands in the bronchial tree. The sympathetic fibers of the pulmonary plexuses are postsynaptic fibers. Their cell bodies are in the paravertebral sympathetic ganglia of the sympathetic trunks. The sympathetic fibers are active during the fight or flight mode, so they cause bronchodilation, vasoconstriction in the pulmonary vessels, and inhibit the secretion in the alveolar glands of the bronchial tree. The visceral afferent fibers of the pulmonary plexuses are either reflexive, meaning they coordinate an automatic response to a stimulus, or nociceptive, meaning they respond to painful stimuli. Reflexive fibers travel with the parasympathetic fibers and carry impulses responsible for reflexive control, such as coughing. Nociceptive fibers from the visceral pleura and bronchi accompany the sympathetic fibers and respond to painful stimuli. Finally, the nerves of the parietal pleura derive from the intercostal and phrenic nerves. The costal pleura and the peripheral part of the diaphragmatic pleura are supplied by intercostal nerves, which mediate both the sensation of touch and pain. The central part of the diaphragmatic pleura and the mediastinal pleura are supplied by the phrenic nerves. Alright, as a quick recap, the lungs are located on each side of the thorax and are covered by the pleura. They have an apex, a base, 3 surfaces, costal, mediastinal, and diaphragmatic, and 3 borders, anterior, inferior, and posterior. The right lung is divided by the horizontal fissure and oblique fissure into 3 lobes, while the left lung is divided by the left oblique fissure into 2 lobes, and, due to the cardiac notch, on the anterior-inferior aspect of the superior lobe, there's the lingula. The tracheobronchial tree begins below the larynx with the trachea, which splits into the main bronchi, which further split into secondary lobar bronchi, tertiary segmental bronchi, and at the tertiary level, the right lung can be divided into 10 bronchopulmonary segments, and the left lung into 8 to 10 bronchopulmonary segments. The tertiary segmental bronchi then split into conducting bronchioles, terminal bronchioles, and respiratory bronchioles, which contain the alveoli. The functional circulation of the lungs consists of the right and left pulmonary arteries, which supply oxygen-poor blood to the lungs, and the 4 pulmonary veins, which carry oxygen-rich blood back to the heart. The nutritive circulation is assured by the 2 left bronchial arteries and the single right bronchial artery. The right and left bronchial veins are responsible with venous drainage along with the pulmonary veins in some regions. Lymphatics of the lungs and pleura include the superficial and deep lymphatic plexuses. Finally, nerves come from the pulmonary plexuses and contain parasympathetic, sympathetic, and afferent fibers. The pleura is a thin membrane that covers each of our lungs and surrounding pulmonary cavity, and it can be subdivided into 2 layers. The visceral pleura, which intimately adheres to the lungs, and the parietal pleura, which lines the rest of the pulmonary cavity. Between these 2 pleural layers, there's the pleural cavity, which is normally filled with a thin film of fluid in order to lubricate the pleural surfaces and allow them to slide smoothly over each other during each breath. Now, on the medial part of each lung, there's a pulmonary hilum, where the root of the lung passes through. The root of the lungs is made of structures like the tracheobronchial tree, as well as arteries and veins. At this level, the visceral and parietal pleura are continuous, making just one structure. To make this easier, you can imagine an underinflated balloon through which you press your fist into. The fist representing the root of the lung, and the balloon representing the visceral and parietal pleura. As you can see, the parietal and visceral pleura are one continuous layer. However, they are reflected on different surfaces. Now, the visceral pleura covers the entire lung and adheres intimately to all of its surfaces, including the ones between the fissures of each lung. The visceral pleura is continuous with the parietal pleura at the hilum of the lung. The parietal pleura is thicker than the visceral one, lines the pulmonary cavities, and adheres to the thoracic wall, mediastinum, and diaphragm. The parietal pleura actually has 4 parts: costal, mediastinal, diaphragmatic, and cervical pleura. The costal pleura covers the internal surface of the thoracic wall, from which it's separated by the endothoracic fascia, a thin layer of loose connective tissue that comes in handy during surgical procedures, making it really easy to separate the lungs from the thoracic wall. The mediastinal pleura covers the lateral aspects of the mediastinum, which is a space between the lungs and continues as cervical pleura superiorly in relation to the root of the neck. It's also continuous inferiorly with the diaphragmatic pleura, and with the costal pleura anteriorly and posteriorly. At the hilum, the mediastinal pleura changes direction laterally onto the root of the lung to become one with the visceral pleura. Superior to the hilum is a continuous sheet passing between the sternum and vertebral column. The diaphragmatic pleura covers the superior surface of the diaphragm on each side of the mediastinum, minus where the diaphragm is fused with the pericardium, and minus the diaphragm's costal attachments to the xiphoid process anteriorly, and to the 11th and 12th rib laterally. Finally, the cervical pleura is basically a continuation of the costal and mediastinal pleura and covers the apex of the lungs, which is the part that extends through the superior thoracic aperture into the root of the neck. Over the apex, the cervical pleura forms the pleural cupula, which domes over the apex that reaches its crest at about 2 to 3 centimeters superior to the clavicle at the level of the neck's first rib. The cervical pleura is made stronger by a fibrous extension of the endothoracic fascia, called the suprapleural membrane. This membrane attaches to the internal border of the first rib and the transverse process of C7 vertebra. So you see, the parietal pleura covers many different thoracic surfaces, and in doing so, creates different lines called lines of pleural reflection. There are 3 lines of pleural reflection on each side of the pulmonary cavities: sternal, costal, and vertebral. By understanding these pleural lines of reflection and how to find them with surface anatomy landmarks, we can locate the boundaries of the pleural cavity, which is important during clinical interventions needed to access the pleural space between the parietal and visceral pleura. The sternal lines of reflection occur anteriorly at the point where the costal pleura is continuous with the mediastinal pleura. They start superiorly from the cupula and descend inferior-medially, pass posterior to the sternoclavicular joints, and meet at the anterior median line, at which point they descend together between the levels of costal cartilages 2 through 4, and then they split up again. At this point, the sternal lines become asymmetrical, because the heart is positioned more to the left, so it leaves a bigger impression on the left lung. So, the right sternal line continues to descend along the anterior medial line, posterior to the xiphoid process, at which point it turns laterally and becomes the costal line. The left sternal pleural reflection descends on the anterior medial line only to the level of the 4th costal cartilage, and at this point, it passes to the left margin of the sternum and continues to the 6th costal cartilage, creating a notch as it runs lateral to the bare area of the pericardium, located roughly at the left side of the midclavicular line. And this is where the pericardium is in contact with the anterior thoracic wall. At this point, the sternal line becomes the costal line. Now, the costal lines continue the sternal lines, and they occur at the point where the costal pleura becomes continuous with the diaphragmatic pleura inferiorly. So the right costal line continues its journey from the anterior medial line. The left costal line continues its journey near the midclavicular line because of the bare area of pericardium on the left. Other than this, the right and left costal lines are symmetrical. They continue to descend posteriorly, and then they make a turn around the 8th rib at the midclavicular lines, and then another turn in the 10th rib at the mid-axillary lines, and then become continuous posteriorly with the vertebral lines at the necks of the 12th ribs. Finally, the vertebral lines of pleural reflection occur more gradually where the costal pleura becomes continuous with the mediastinal pleura posteriorly. The vertebral lines are parallel to the vertebral column and run in the paravertebral planes from T1 through T12. Afterwards, they become continuous with the costal lines. Now, during expiration, the lungs don't occupy the entire pulmonary cavities, so the diaphragmatic pleura is in contact with the lowest part of the costal pleura. These pleural spaces are called the costodiaphragmatic recesses, which act as gutters lined in pleura, and they surround the upward convexity of the diaphragm and the thoracic wall. There are also some smaller pleural recesses that are located posterior to the sternum, where the costal pleura is in contact with the mediastinal pleura, and these are called costomediastinal recesses. The left recess is larger because it's less occupied due to the cardiac notch in the left lung. Now, let's catch a breath with a pop quiz. Can you recall the 4 parts of the pleura as well as the lines of pleural reflection? Alright, as a quick recap. The lungs are located on each side of the thorax and are covered by the pleura. The visceral pleura adheres intimately to the lung, and the parietal pleura lines the pulmonary cavities. Between them, there's a thin film of fluid located within the pleural cavity, which allows for lubrication during respiration. Now, the parietal pleura has 4 parts: costal, mediastinal, diaphragmatic, and cervical pleura. When the parietal pleura changes direction, it forms 3 lines of pleural reflection: sternal, costal, and vertebral. The lungs don't occupy the entire pulmonary cavity during expiration, and as a consequence, the pleural spaces remaining form the costodiaphragmatic recesses and the costomediastinal recesses.
The thorax is the area between the neck and abdomen and consists of the thoracic cavity, its contents, and the walls that surround it. The thoracic skeleton forms the osteocartilaginous thoracic cage that protects the thoracic viscera and some of the abdominal organs. The skeleton is made up of the sternum, 12 pairs of ribs and associated costal cartilages, as well as 12 thoracic vertebrae and intervertebral discs interposed between them. The ribs and costal cartilages form the largest part of the thoracic cage, and both can be identified numerically, going from 1 to 12 for the ribs, and going from 1 to 10 for the costal cartilage, as ribs 11 and 12 do not have an associated costal cartilage. Now, the true thoracic wall includes the thoracic cage and the muscles between the ribs and the skin, as well as subcutaneous tissue, muscles, and fascia that cover its anterolateral aspect. The structures that cover its posterior aspect are considered to belong to the back. Additionally, the mammary glands of the breasts lie within the thoracic wall subcutaneous tissue, and the anterolateral axio-appendicular muscles are also considered part of the thoracic wall. Okay, let's start talking about the ribs, which form most of the thoracic cage. They're curved, flat, lightweight, and highly resilient bones. Each rib has a spongy interior that contains bone marrow or hematopoietic tissue, which forms blood cells. There are 3 types of ribs based on their connection to the sternum: true, false, and floating ribs. The true, or vertebrosternal ribs, are the first 7 pairs of ribs, and they attach directly to the sternum through their own costal cartilages. The false, or vertebrochondral ribs, are the 8th, 9th, and usually the 10th pair of ribs, and their cartilages are connected to the cartilage of the rib above them. Consequently, their connection to the sternum is indirect. The floating ribs, or vertebral or free ribs, are the 11th, the 12th pair of ribs, and sometimes the 10th pair of ribs. The cartilages of these ribs don't connect anteriorly to the sternum at all. Instead, they end up in the posterior abdominal musculature. Ribs can further be classified as either typical or atypical ribs. Typical ribs are the 3rd through the 9th pair of ribs and have the following components: head, neck, tubercle, and body. On the posterior view, the head of a typical rib is wedge-shaped and has 2 facets, superior and inferior, that are separated by the crest of the head. The inferior facet articulates with the numerically corresponding vertebra, and the superior facet articulates with the vertebra above it. The neck connects the head with the body at the level of the tubercle. The tubercle, located at the junction of the neck and body, has a smooth articular part that connects with the corresponding transverse process of the vertebra and a rough non-articular part where the costotransverse ligament attaches. The body is thin, flat, and curved, especially at the costal angle, where the rib makes an anterolateral turn. This angle also demarcates the lateral limit of attachment of the deep back muscles to the ribs. The internal surface of the body is concave and has a costal groove that's parallel to the interior border of the rib, which provides protection for the intercostal nerves and vessels at that level. Now, the first, second, 10th through 12th rib are atypical because they are unlike the typical ribs in various ways. So, the first rib is the broadest, shortest, and most sharply curved of the 7 true ribs. Its body is the widest and is nearly horizontal. Its head has a single facet because it only articulates with the T1 vertebra, and its body has 2 transverse grooves crossing its superior surface for the subclavian artery and vein. The grooves are separated by a scalene tubercle and ridge to which the anterior scalene muscle is attached. It also has a tubercle which articulates with the transverse process of T1. Now, the second rib has a thinner and less curved body, and it's longer than the first rib. Its main atypical feature is a rough area on its upper surface called the tuberosity for serratus anterior, where the serratus anterior originates. Its head has 2 facets for articulation with the bodies of T1 and T2 vertebrae. The 10 through 12th ribs, like the first rib, only have 1 facet on their heads and articulate with a single vertebra. The 11th and 12th ribs are short and don't have a neck or tubercle. Now, the head of each rib articulates with thoracic vertebrae via costovertebral joints, which are synovial plane joints. Regarding ribs 2 through 9, the head of each rib articulates with the superior costal facet of the vertebral body of the same number and with the inferior costal facet of the vertebral body above it and to the intervertebral disc between them. So, for example, the head of rib 4 articulates with the superior costal facet of the vertebral body of T4 and with the inferior costal facet of the vertebral body of T3 and with the intervertebral disc between those 2 vertebrae. Unlike ribs 2 through 9, the 1st, 11th, 12th, and sometimes the 10th rib only articulate with a single vertebral body at the same vertebral level as the rib. For example, rib 11 articulates with T11. Then there are the costa transverse joints, which are also synovial plane joints. Regarding ribs 1 through 10, the tubercle of the rib articulates with the transverse process of the vertebra of the same number. Ribs 11 and 12 don't articulate with the transverse process of vertebrae of the same number. Now let's take a deep breath and play a fun game. Let's see if you can identify which atypical rib we're showing in these images and what the structures are that form a typical rib. Moving on to the sternum, which is a flat, elongated bone that forms the middle of the anterior part of the thoracic cage. The sternum is the protector of the mediastinal viscera, especially the heart. It consists of 3 parts: manubrium, body, and xiphoid process. Let's now identify each structure and their components one by one in both anterior and lateral views. The manubrium is a trapezoidal bone and is the widest and thickest part of the sternum. The jugular notch, or the suprasternal notch, is the superior and concave border of the manubrium and can be easily palpated. The notch is deepened by the medial ends of the clavicles, which are much larger than the small clavicular notches in the manubrium found laterally on either side. Now, the sternoclavicular joint is a saddle type of synovial joint, and the joints form between the ends of the clavicles and the clavicular notches of the manubrium, as well as the first costal cartilages. Inferior and lateral to the clavicular notch, there's the first sternocostal joint, which is the costal cartilage of the first rib attached to the lateral border of the manubrium of the sternum, which is classified as a primary cartilaginous joint. Between the manubrium and body of the sternum, there's the manubriosternal joint, which is a secondary cartilaginous joint. Now, the manubrium and body of the sternum lie in different planes superior and inferior to their junction. Because of this, their junction forms an angle called the angle of Louis or the sternal angle, which you can see better in a lateral view. The sternal angle is palpable and even visible in young individuals. The sternal angle lies at the level of T4, T5 intervertebral disc and the space between the third and fourth thoracic spinous processes. The sternal angle also marks the level of the second pair of costal cartilages. Now, the left side of the manubrium is anterior to the arch of the aorta, and its right side overlies the merging of the brachiocephalic veins to form the superior vena cava. The superior vena cava then passes inferiorly deep to the manubrium and manubriosternal joint, but it projects as much as a finger breadth to the right margin of the manubrium. The body of the sternum is longer, narrower, and thinner than the manubrium, and is located roughly at the level of T5 through T9 vertebrae. Particularly, its width varies due to the scalloping of the lateral borders of the costal notches. Finally, the body of the sternum articulates with the costal cartilages of ribs 2 through 7 through synovial plane joints to form the rest of the sternocostal joints. The xiphoid process is the smallest and most variable part of the sternum. It's thin and elongated, and its end lies at the level of T10 vertebrae. Between the body of the sternum and the xiphoid process, there's the xiphosternal joint, which is a primary cartilaginous joint. The xiphoid process is important because the xiphosternal joint indicates the inferior limit of the central part of the thoracic cavity projected onto the anterior body wall. This joint is also the site of the infrasternal angle or subcostal angle formed by the left and right costal margins. It's also a midline marker for the superior limit of the liver, the central tendon of the diaphragm, and the inferior border of the heart. Now let's look at the big picture. So there are 11 intercostal spaces that separate the ribs and their costal cartilages from one another. The name of each intercostal space is according to the rib that forms the superior border of the space. For example, the sixth intercostal space is between ribs 6 and 7. The space below the 12th rib doesn't lie between any ribs, so it's called the subcostal space. So, at the end of the day, the thoracic cage forms a complete wall peripherally, but it's open superiorly and inferiorly. The superior thoracic aperture, or opening, is smaller and allows communication with the neck and upper limbs, while the inferior thoracic aperture is larger and provides the ring-like origin of the diaphragm, which completely closes this opening. The superior thoracic aperture is bounded posteriorly by T1 vertebra, with its body protruding anteriorly into the opening. Laterally, there's the first pair of ribs and their costal cartilages. Anteriorly, there's the superior border of the manubrium. Structures that pass through the superior thoracic aperture include the trachea, esophagus, nerves, and vessels that supply and drain the head, neck, and upper limbs. The inferior thoracic aperture is bounded posteriorly by the 12th thoracic vertebra, and the body of this vertebra also protrudes anteriorly into the opening. Posterolaterally, there are the 11th and 12th pair of ribs. Anterolaterally, there are the joined costal cartilages of ribs 7 through 10, forming the costal margins. Anteriorly, there's the xiphosternal joint. The diaphragm closes the inferior aperture and separates the thoracic and abdominal cavities almost completely. The structures that pass to and from the thorax to the abdomen pass through openings that traverse the diaphragm, such as the esophagus and inferior vena cava, or pass posterior to the diaphragm, like the aorta. In this image, can you identify the borders of the superior thoracic aperture? How about the inferior thoracic aperture? Finally, the thoracic wall with all its bones and joints are essential during respiration, along with the diaphragm. They increase or decrease the intrathoracic volume and diameters of the thorax, resulting in changes of pressure. During expiration, the diaphragm, intercostal muscles, and other muscles relax, reducing the diameter of the thoracic wall and increasing intrathoracic pressure to expel air from the lungs. During inspiration, the vertical dimension of the thoracic cavity increases as contraction of the diaphragm causes it to descend inferiorly into the abdominal cavity. The AP dimension of the thorax also changes considerably during inspiration as the intercostal muscles contract. During intercostal contraction, the costotransverse joints of ribs 1 through 7 move around an axis passing through the neck of the ribs, causing the anterior sternal ends of the ribs to rise to create a pump handle movement. Additionally, the transverse dimension of the thorax also increases during inspiration, as contraction of the intercostal muscles raises the middle, lateral-most parts of the lateral lower ribs to create a bucket handle movement, made possible by the 8th through 10th costotransverse joints having flat articular surfaces which allow gliding. These combinations of movements allow the thoracic cage to move anteriorly, superiorly, and laterally to accommodate air inflow during inspiration. Alright, as a quick recap, the thoracic wall includes the thoracic cage and the muscles between the ribs and the skin, as well as subcutaneous tissue, muscles, and fascia that cover its anterolateral aspect. Of the 12 pairs of ribs, the first 7 pairs are true ribs, and they attach directly to the sternum through their own costal cartilages. The 8th, 9th, and usually the 10th rib are false, and their cartilages are connected to the cartilage of the rib above them. The 11th and 12th pair of ribs are floating ribs, and they're not connected to the sternum. The 3rd through 9th pair of ribs are typical ribs. The 1st, 2nd, and 10 through 12th ribs are atypical. The sternum has 3 parts: manubrium, body, and xiphoid process. The manubrium has a jugular notch, clavicular notches, and between the manubrium and body of the sternum is the manubriosternal joint. At this level, there's the sternal angle, which lies at the level of T4, T5 intervertebral disc and marks the level of the second pair of costal cartilages. The xiphoid process lies at the level of T10 vertebrae. The ribs and their costal cartilages are separated from one another by the 11 intercostal spaces, and each space gets its name from the rib that forms the superior border of the space. The superior thoracic aperture allows passage of the structures between the thorax and the neck, while the inferior thoracic aperture is bounded inferiorly by the diaphragm and is where structures pass to and from the abdomen. Finally, during forced inspiration, the thoracic cage increases its vertical height through the diaphragmatic contraction. The antero-posterior diameter of the thoracic wall through a pump handle movement, and the transverse diameter through a bucket handle movement.
The thoracic wall surrounds the thoracic cavity, which is the anatomical region where viscera, like the heart and lungs, can be found. The thoracic wall contains a variety of muscles, where many of the muscles that cover and attach to the thoracic wall have a primary action elsewhere, such as the arms, neck, and abdomen, and it's their secondary actions that affect the movements of the thoracic wall. For example, the pectoralis major and pectoralis minor muscles overlay the thoracic wall, but they are primarily involved with movements of the upper limb, and their secondary action is to act on the thoracic wall as accessory muscles of respiration. However, the thoracic wall also does have muscles that have their primary action in the thoracic wall, and these are called the true muscles. They are the serratus posterior, levatorius costarum, subcostals, transversus thoracis, and the innermost internal and external intercostals. Let's start with the two serratus posterior muscles. There's a serratus posterior superior muscle and serratus posterior inferior muscle on each side. The serratus posterior superior muscles have their proximal attachment at the nuchal ligament and the spinous processes of C7 through T3 vertebrae, and their distal attachment at the superior borders of the second through fifth ribs. Its main action is the elevation of the superior four ribs during inspiration. The serratus posterior inferior muscles have their proximal attachment at the spinous processes of T11 through L2 vertebrae and their distal attachment at the inferior borders of 9th through 12th ribs near their angles. Its main action is depressing the inferior ribs in order to prevent them from being pulled upwards by the diaphragm. Both of these muscles have been shown to have a role in proprioception, meaning that they might make you aware of the position of the body. For example, when you're lying in bed with your eyes closed, these muscles, among others, could send signals to the brain regarding where you are and what's your position in relation to the bed. Next, the levatorius costarum muscles are 12 triangle-shaped muscles with a proximal attachment to the transverse processes of C7 through T11 vertebrae and distal attachments to subadjacent ribs between the tubercle and the angle of that rib. Their main action is to elevate the ribs. Then there are the intercostal muscles, which are a group of muscles that occupy the space between the ribs. The external intercostal muscles form the superficial layer, while the internal intercostal muscles form the inner layer. Now, the innermost intercostal muscles are fibers of the internal intercostal muscles that are the deepest fiber layer and lie internal to the intercostal nerve and vessels. All three intercostal muscles have the same origin and insertion. So their proximal attachment is at the inferior border of the ribs above and their distal attachment at the superior border of the rib below. For example, the intercostals at the third intercostal space all attach to the inferior border of the third rib and the superior border of the fourth rib and so on. In addition, they are all innervated by the intercostal nerves traveling in their respective intercostal spaces. The main differences between the intercostals are their fiber orientation and how far they span anteriorly to posteriorly. So let's look at the 11 pairs of external intercostal muscles that occupy the intercostal spaces from the tubercles of the rib posteriorly to the costochondral junctions anteriorly, where the most anterior muscle fibers are actually replaced by fascia called the external intercostal membranes. These muscles run infro-anteriorly from the rib above to the rib below. To visualize this, the fibers run in the same way the fingers of your hand would if you placed your hands in the pockets of your jeans. The lower external intercostals are continuous anteriorly with the external oblique muscles in the abdominal wall. The external intercostal muscles elevate the ribs during forced inspiration. Then there are the 11 pairs of internal intercostal muscles, which run deep to and at right angles to the external intercostals. This means that their muscle fibers run infero-posteriorly from their origin compared to infero-anteriorly like the external intercostals. To visualize this, the fibers run in the same way your fingers would if you were to cross your arms to hug yourself and place your hands on your hips. The internal intercostal attaches to the bodies of the ribs and their costal cartilages all the way to the sternum anteriorly and posteriorly as far as the angles of the ribs. Between the ribs and medial to the angles, the internal intercostal muscles are replaced by fascia called the internal intercostal membranes. The inferior internal intercostal muscles are continuous with the internal oblique muscles in the anterior abdominal wall. The internal intercostal muscles mostly play a role during expiration. Finally, the innermost intercostal muscles are basically the deeper parts of the internal intercostal muscles, and are separated from them by intercostal nerves and vessels. These muscles pass between the internal surfaces of adjacent ribs and occupy the most lateral parts of the intercostal spaces. And just like the internal intercostal muscles, they likely play a role during expiration. Now, take a moment and try and identify some of the structures we have just talked about on these images. Now, let's have a quick look at the anatomy and physiology of breathing. The diaphragm is the main muscle in inspiration, while expiration is usually passive, except when a person is trying to exhale against resistance, like when blowing air into a balloon, or when one's trying to expel air more rapidly, like when coughing or sneezing. Both external and internal intercostals are active during respiration, but their action is mostly isometric, meaning their contraction does not actually cause movement of the thoracic cage. This isometric contraction is to support the intercostal space, especially during inspiration when internal thoracic pressures are lowest. However, during forced respiration, these muscles become more active and will produce movement of the ribs. Let's take a look at this image. Now, take a really deep breath, literally, do it, and see what happens. When undergoing forced inspiration, the external intercostals and part of the internal intercostals called the interchondral portion contract and rotate the ribs superiorly at their posterior axes. The result is the elevation of the ribs and an increase of the anteroposterior diameter. This occurs because the ribs are hinged posteriorly by a fixed vertebral column and anteriorly by a movable sternum. During forced expiration, the interosseous part of the internal intercostal muscles contract and rotate the ribs inferiorly at their posterior axes. The result is the depression of the ribs and sternum and the decrease in the anteroposterior diameter. So, this is to say that the interosseous and the interchondral parts of the internal intercostal muscles have two different actions during forced respiration, even though these muscle fibers have the same orientation. This all occurs because as the ribs move postero-anteriorly, they descend as they run towards the sternum. Their lowest point is approximately at the junction with the costal cartilage, and then ascending toward the sternum. The interchondral fibers of the internal intercostals are medial to this point. Therefore, their fibers are parallel to the slope of the ribs, and their contraction causes the hinged ribs to rotate superiorly based on their biomechanical pull. The interosseous part of the internal intercostal is lateral to this low point, causing its fibers to be perpendicular to the slope of the rib, and contraction of these fibers rotates the ribs inferiorly, pulling them down. Other muscles in the thoracic wall include the subcostal muscles. They are usually well developed only in the lower thoracic wall, and they vary in size and shape. Proximally, they attach to the internal surface of lower ribs near their angles, and distally, they attach at the superior border of the second or third ribs below. This means that these muscles actually cross one or two intercostal spaces. The subcostal muscles run in the same direction as the internal intercostals, and are thought to act in the same way as the internal intercostals. Now, the transversus thoracis muscles have their proximal attachment at the posterior surface of the lower sternum and their distal attachment at the internal surface of the costal cartilages 2 through 6. They are continuous with the transversus abdominis muscles in the anterolateral abdominal wall. They may slightly depress the ribs during expiration and might provide proprioceptive information. Both of these muscles are innervated by the intercostal nerves. Finally, let's move on to the endothoracic fascia, which is a thin layer that lies between the internal aspect of the thoracic cage and the lining of the pulmonary cavities, and attaches the deeper situated costal parietal pleura to the thoracic wall. The endothoracic fascia continues over the apices of the lungs, where it becomes more fibrous and is called the suprapleural membrane. Alright, as a quick recap. The true muscles of the thoracic wall are serratus posterior, levitoris costarum, subcostals, transversus thoracis, and the intercostals. The role of the intercostal muscles in respiration is to support the intercostal space, especially during inspiration when the internal thoracic pressures are the lowest. During forced inspiration, the external intercostals and the interchondral portion of the internal intercostal muscles contract and rotate the ribs superiorly at their posterior axes, elevating the ribs. During forced expiration, the interosseous part of the internal intercostal muscles contract and rotate the ribs inferiorly at their posterior axes, depressing the ribs. The endothoracic fascia is a thin layer that lies between the internal aspect of the thoracic cage and the lining of the pulmonary cavities.
There are numerous vessels and nerves that course throughout the bony and muscular architecture of the thoracic wall, and they provide innervation and blood supply to the structures within and around the thoracic cage. First, let's have a look at the contents of the intercostal space, specifically the neurovascular bundle containing the intercostal nerve, artery, and vein. It is important to remember the order of these structures, with the most superior structure being the intercostal vein, and below it comes the artery, and below the artery, the nerve. To easily remember this, think VAN, or think about a van that's blue at the top, red in the middle, and yellow in the inferior part. The inferior portion of the ribs also have a costal groove, which only provides partial protection for these structures, so they can be damaged during penetrating intercostal injuries or any intervention that requires intercostal access. Now, let's talk about the nerves. There are 12 pairs of thoracic spinal nerves which supply the thoracic wall. They leave the intervertebral foramina as soon as they are formed, dividing into anterior and posterior rami. Now, the anterior rami of nerves T1 through T11 form the intercostal nerves that run along the intercostal spaces along the inferior borders of the ribs, with the third intercostal nerve traveling between the third and fourth ribs. The anterior ramus of nerve T12 that courses inferior to the 12th rib is the subcostal nerve. The intercostal nerves give anterior and lateral cutaneous branches to innervate the thorax and abdominal wall, muscular branches to supply the muscles of the thoracic wall, and they give rami communicantes or communicating branches that connect the intercostal nerves to a sympathetic trunk on the same side. The posterior rami of thoracic spinal nerves pass posteriorly, lateral to the articular processes of the vertebrae in order to supply the joints, deep back muscles, and skin of the posterior thoracic region. Now, the intercostal nerves are either typical or atypical, and the typical ones are the 3rd through the 6th pair. These nerves enter the medial-most parts of the posterior intercostal spaces. Initially, they run with the endothoracic fascia just between the parietal pleura and the internal intercostal membrane. Near the angles of the ribs, these nerves pass between the internal intercostal and the innermost intercostal muscles. From here, they continue to course in or inferior to the costal grooves, running inferior to the intercostal arteries. Keep in mind that the arteries run inferior to the intercostal veins. Near the angles of the ribs, collateral branches arise and run along the superior border of the rib below. The nerves continue anteriorly between the internal and innermost intercostals and supply these muscles and other muscles, and also give rise to the lateral cutaneous branches in the mid-axillary line. Anteriorly, the nerves appear on the internal surface of the internal intercostal muscle. Near the sternum, these nerves turn anteriorly and pass between the costal cartilages to become anterior cutaneous branches. Atypical intercostals are the first two intercostal nerves which run on the internal surface of the first and second ribs, not along the inferior margin in the costal groove, and the 7th through 11th nerves which eventually become thoracoabdominal nerves of the anterior abdominal wall. Most thoracic spinal nerves, specifically T2 through T12, give rise to the dermatomal map of the trunk through their posterior ramus and the lateral and anterior cutaneous branches of its anterior ramus. This dermatomal map extends from the posterior median line to the anterior median line, and it represents the area of skin supplied by the spinal nerves. Exact dermatomal distributions may vary depending on the source, however they are generally agreed upon with certain dermatomes acting as key landmarks. For example, dermatome T4 includes the nipple and T10 includes the umbilicus. Almost there. Let's see if you can identify the typical intercostal nerves in this picture. Alright, finally, let's look at the arterial supply to the thoracic wall, which comes from the posterior intercostal and subcostal arteries arising from the thoracic aorta, the internal thoracic or mammary artery coming from the subclavian artery, and the supreme or superior intercostal artery arising from the costocervical trunk of the subclavian artery, and the superior and lateral thoracic arteries from the axillary artery. With the exception of intercostal space 10 and 11, each intercostal space is supplied by a large posterior intercostal artery and a small pair of anterior intercostal arteries. The posterior intercostal arteries of the first and second intercostal spaces arise from the supreme or superior intercostal artery, which is a branch of the costocervical trunk of the subclavian artery. The posterior intercostal arteries of the 3rd through the 11th intercostal spaces arise posteriorly from the thoracic aorta. All posterior intercostal arteries give rise to a dorsal branch that accompanies the posterior ramus of the spinal nerve to supply the spinal cord, vertebral column, back muscles, and skin. They also give rise to a small collateral branch that crosses the intercostal space and runs along the superior border of the rib below. The posterior intercostal arteries accompany the intercostal nerves through the intercostal spaces. Close to the angle of the rib, the arteries enter the costal grooves, where they lie between the intercostal vein and nerve. At first, the arteries run in the endothoracic fascia between the parietal pleura and the internal intercostal membrane, and then they run between the innermost intercostal and internal intercostal muscles. They have terminal and collateral branches that anastomose anteriorly with anterior intercostal arteries. Now, the ipsilateral pairs of anterior intercostal arteries supply the anterior parts of the upper 9 intercostal spaces. They pass laterally in the intercostal space, one near the inferior margin of the superior rib and the other near the superior margin of the inferior rib. In the first 2 intercostal spaces, they lie initially in the endothoracic fascia between the parietal pleura and the internal intercostal muscles. They supply the intercostal muscles and send branches through them to supply the pectoral muscles, breast, and skin. They're missing from the inferior 2 intercostal spaces because these spaces are supplied only by the posterior intercostal arteries and their collateral branches. Then there are the internal thoracic arteries, previously called the internal mammary arteries, arise in the root of the neck from the inferior surfaces of the first parts of the subclavian arteries. Then they descend into the thorax posterior to the clavicle and first costal cartilage. Then they descend on the internal surface of the thorax lateral to the sternum and posterior to the upper 6 costal cartilages and internal intercostal muscles. After going down past the second costal cartilage, the internal thoracic arteries run anterior to the transversus thoracis muscle. They terminate in the 6th intercostal space by dividing into the superior epigastric and the musculophrenic arteries. They also directly give rise to the anterior intercostal arteries that supply the superior 6 intercostal spaces. There is also the subcostal artery, which is a branch of the thoracic aorta. It courses along the inferior border of the 12th rib and provides blood supply to muscles of the anterolateral abdominal wall. Last but not least, let's have a quick look at the veins of the thoracic wall. The intercostal veins accompany the intercostal arteries and nerves and lie most superior in the costal grooves. There are 11 posterior intercostal veins and 1 subcostal vein on each side. The posterior intercostal veins anastomose with the anterior intercostal veins, which are tributaries of the internal thoracic veins. As they get close to the vertebral column, the posterior intercostal veins receive a posterior branch, which accompanies the posterior ramus of the spinal nerve of that level, and an intervertebral vein that drains the vertebral venous plexuses of the vertebral column. Now, most posterior intercostal veins, specifically those who drain the 4th through the 11th intercostal space, end in the azygous or hemiazygous vein system. The azygous system conveys venous blood to the superior vena cava. The posterior intercostal veins of the first intercostal space enter directly into the right and left brachiocephalic vein. The posterior intercostal veins of the second and third and sometimes fourth intercostal spaces join to form a trunk called the superior intercostal vein. The right superior intercostal vein is usually the final tributary of the azygous vein before it enters the superior vena cava. The left superior intercostal vein usually empties into the left brachiocephalic vein. The internal thoracic veins are the companion veins of the internal thoracic arteries. And one last quiz before the recap. Can you label the arteries in this picture? Alright, as a quick recap, the contents of the intercostal space can be easily remembered as van, meaning the most superior is the intercostal vein, below it comes the artery, and below the artery, the nerve. There are 12 pairs of thoracic spinal nerves that divide into a posterior rami as well as anterior rami that continues as the intercostal nerve. The typical intercostal nerves are the 3rd through the 6th intercostal nerves. Through the posterior ramus and the lateral and anterior cutaneous branches of the anterior ramus, the cutaneous branches of the T2 through T12 thoracic spinal nerves supply the dermatomes of the trunk that extends from the posterior median line to the anterior median line. The arterial supply to the thoracic wall comes from the posterior intercostal and subcostal arteries arising from the thoracic aorta, the internal thoracic and superior intercostal artery, and the superior and lateral thoracic arteries from the axillary artery. The veins of the thoracic wall are the intercostal veins that accompany the intercostal arteries and nerves, and they mostly drain into the azygous system. The posterior intercostal veins of the first intercostal space enter directly into the right and left brachiocephalic vein. The posterior intercostal veins of the second and third and sometimes fourth intercostal spaces join to form a trunk called the superior intercostal vein.